LAO.
Sean Martin with the Legislative Analyst's Office. We have reviewed the AIDS Drug Assistance Program estimate, and at this time we're not recommending any adjustments to it, but we'll look at it again at the time of the May revision and recommend adjustments at that time if we find problems with it. With regards to the budget change proposal, we haven't raised any issues. And with regards to the proposal that's in the agenda, we haven't, this is relatively new to us, we haven't had a time to look at it and evaluate what its fiscal effect would potentially be.
And were all your questions answered? Okay, excellent. All right, hearing that, we'll open it up for public comment. Please step forward. And again, we're taking all three items under the Office of AIDS, ADAP, the eligibility verification, and modernization.
Aaron Fox, Los Angeles LGBT Center, also the co-chair of the California HIV Alliance, which is a group of statewide organizations that are either service providers or advocacy groups, many of whom are represented behind me. Madam Chair and members of the committee, we're extremely happy to see that the proposal that took a lot of work on the part of not only the department, but the committee, and I think stakeholders as well, around modernizing eligibility to make it fair and equitable, especially with a changing face of HIV and demographics of the epidemic changing from a time when these rules were put into effect in the 1980s. And so we would definitely be in support of this. We think, especially being that this does not cost any general fund and is actually going to end up saving ADAP money in the long run, we think this is sort of a win-win for everybody involved. And part of the proposal that's been put forth by the administration, because the 1115 waiver is going to be ending, there's going to be around $18 million that is going to be taken out of the ADAP program that was safety net care pool funding through the waiver. That money was put in to ADAP in lieu of general fund dollars that was existing in the program prior to that point. At one point, the state was spending almost $150 million in general fund on HIV services as a whole, prevention, care, treatment. And at this point, we're, I think, maybe around $5 million with the $3 million from last year and some surveillance money. So I think overall, when we see that we're still seeing money taken out of the program, and there hasn't been a significant effort on the part of the administration to reinvest specifically in HIV and in public health in general, it's very concerning to us, and especially being this program is going to be serving more people. And while we understand that the department has to meet its obligations to HRSA with regard to the staffing request, we think that because there are some issues with the programs, specifically OAHIP and ADAP running the way that they should be running because of the number of people that are now in them, we do think that some of those staff should be dedicated to making sure that those programs run and run sustainably so that people can make sure that they're not dropped out of insurance. We also have put forth a proposal to the committee. Part of that would be $3 million in general fund to stabilize the OAHIP program. $2 million of that would go to the enrollment workers that Dr. Mark spoke of. They are extremely overburdened and overtaxed in the work that they do. Oftentimes, they end up being paid by the organizations that house them rather than the state actually paying for them. And so it is our perspective that if those staff were to move forward, that we would like to see some of those staff be dedicated to making sure that that program works the way that it's supposed to. Thank you.
Thank you very much. Next witness, please.
Hi again, Craig Pulsper from AIDS Project Los Angeles and also representing the California HIV Alliance. I just wanted to echo my colleagues' statements regarding the importance of reinvesting in HIV. As you know, in 2009, $84 million was cut from HIV programs in the state. And this year, with the loss of safety net care pool funds in October, this leaves little state investment in HIV. So we're really at a turning point in the epidemic with the ACA and new advancements in biomedical prevention, we really have an opportunity to make a significantly reduce HIV infections if we make even a modest reinvestment in programs that have been proven to work. I just want to echo support for the proposal to modernize ADAP and OA-HIP eligibility. This will not have an impact on general fund and increase access to care for thousands of people. I also want to support what Aaron mentioned about allocating funds for enrollment workers and improving administration of ADAP and OA-HIP within the State Office of AIDS. I also want to bring attention to one issue that was mentioned earlier, which was PrEP, or pre-exposure prophylaxis. It's a pill that can be taken once daily to reduce your chance of becoming infected with HIV. It's over 90% effective. Some studies show it's 99 to 100% effective. And we really want to make sure that this is accessible to those who would benefit from it. So we're proposing a PrEP access and affordability program, roughly $3 million, which could be spent in various ways, including outreach and education, patient navigation, provider training, and cost-sharing assistance for uninsured and underinsured individuals. So we look forward to working with the committee on this proposal.
What's the level of availability on that med now in terms of private insurance or?
Yeah, so it's covered, in terms of coverage, it's covered by Medi-Cal, Medicare, and as far as we know, every insurance company in California. So cost is not the main barrier at this point in terms of accessing the drug. People still need to pay for the medical tests associated with PrEP, but a lot of the need is around awareness and also navigating insurance and the various assistance programs that are available. So awareness and uptake is extremely low, and so we're not going to increase utilization without an investment. So.
Excellent. Thank you very much.
Thank you.
Next witness. The first two witnesses were pretty comprehensive in their explanation of the additional ask, so feel free to say ditto if it's applicable.
I'm going to take a bit of a spin on that.
Okay.
My name is David Kilburn. I'm the Executive Director of the San Luis Obispo County AIDS Support Network and the SLO Hep C project. We founded our agency 30-plus years ago in response to the AIDS pandemic. In the late 90s, we saw the need emerging with hepatitis C and how it was affecting our clients. So we formed the hepatitis C project at that time through a grant from the California Endowment. It was a 3-year grant. We proposed to serve 200 people in 3 years. We did that in the first 6 months, and to this date have served over 1,000 people with Hep C. That was a 3-year grant. We've struggled to maintain it. We were going along, finding local resources, and then in 2009, when the budget was cut drastically, all prevention in our county was cut, and a good majority of our services for HIV were cut. So we, as a smaller and mid-sized county, are vastly under-resourced for what the needs are. So I absolutely support, and I will agree with them about our ADAP enrollment workers are inundated right now. We are very limited in the services that we can provide, but our staff is completely dedicated but burning out. So we really need to look at those undersized and under-resourced counties that need to be looked at in budget allocations. Through the California Endowment grant that we had in outreach with Hep C, we saw that dedicated resources, we were able to identify those people, screen them, link them to care, and retain them in care. So I say, as we look at this new emerging time of Hep C treatment, even a small county like San Luis Obispo has made a huge impact. So we really need to commit sources to testing, linkage to care, retention in care, and ultimately prevention. And in both of these epidemics, we need resources. So thank you very much.
Thank you. Thank you very much. Next witness, please. Thank you.
Hi, I'm Emily Hirio, co-chair of the California Hepatitis Alliance, which is an organization of over 100 groups throughout the state addressing viral hepatitis. The California Hepatitis Alliance is requesting $8.6 million in general fund for the next fiscal year that would go to the State Office of AIDS to do 3 things. One would be to provide hepatitis C rapid test kits to community-based HIV testing programs. 2 would be to improve the delivery of viral hepatitis and HIV prevention materials through a syringe exchange clearinghouse that would provide supplies to locally approved syringe programs. And 3 would to support demonstration projects to improve linkage to and retention and care for people living with hepatitis C, which would be modeled after similar successful programs for HIV that the State Office of AIDS has administered in the past and currently. CDPH estimates that there are 750,000 Californians with hepatitis C, and most, 45 to 80%, do not know their status. And only half of those who do know their status have the appropriate medical follow-up. While most of the people with hep C are baby boomers, most new infections are caused by sharing of syringe equipment and injection drug equipment, particularly among young people who inject drugs who are under 30 years of age. It's the leading cause of hepatitis C and the second most common cause of HIV transmissions. And we know that syringe exchange and disposal programs, along with evidence-based drug treatment, hepatitis C testing, and linkage to and retention and care, are truly the cornerstones of an effective strategy to eliminate hep C in communities. And it's critical to note that low-income Californians, African Americans, Latinos, and Native Americans are all disproportionately impacted by the hepatitis C virus. The unchecked spread of the virus really threatens the public health and economic welfare of our state and can cause, among other conditions, cirrhosis, liver cancer, hepatic coma, and even death. We really believe that with a commitment to preventing hepatitis C, linking people to care, and treating hepatitis C, we could stop the spread of the virus, save valuable tax resources, reduce overall healthcare spending, and prevent needless suffering for families in California. Thank you.
Thank you. Next witness.
Chair, members, Kathy Mossberg with the San Francisco AIDS Foundation. I do agree that my colleagues have said, hit mainly all of the high points, so I would just associate myself with their comments and support all of those programs. Just a really quick sort of thematic, the theme here is in HIV and AIDS in particular, what we've seen since the recession is a lot of money out and not a lot of money in. We certainly appreciate the work of this subcommittee and the legislature and the leadership of the Office of AIDS in putting in those limited dollars last year, and we think they've gone to great use and will in the future, but we certainly are asking for a modest investment to get to the point where we can look at, we have all of the resources to get at 0 cases instead of the 5,000 every year. So thank you for your time.
Thank you. Next witness.
Hello, my name is Loris Maddox, and I'm the Executive Director of HIV Education and Prevention Project of Alameda County. We're located in Oakland. We're responsible for operating the longest and largest syringe exchange program in the Bay Area. We're responsible for the city of Oakland and Contra Costa County. So our comprehensive program includes HIV and hepatitis C testing, linkage to care services, overdose prevention, education, and naloxone distribution. Very glad I heard that a lot today. And abscess wound care, referral services, hot meals, and other basic services, basic needs services. Annually, we collect about 1.1 million used syringes in the Bay Area. So that kind of gives you some context of the work that we do. One quick thing too, we receive the same amount of funding from the Alameda County Office of AIDS since 2004. But the volume increases. Just want to point that out. Community-based hepatitis C testing is crucial in the East Bay. There's a lot of advertisements right now. They're in the bus shelters, billboards, radio, and what we're seeing at the community level, our folks, people who inject drugs, African Americans, a lot of them are homeless, of course have some type of mental health issues. When they're coming to us, some of them are coming to us and they're saying, I see that there's a treatment. I saw this on a bus shelter, give me more information about it. That's a spark for us. So it means that they're starting to think about their health, their personal health. So with testing and education, we're able to provide the testing and let them know of their status, and then that can open up the floodgates of enrolling them into some type of health coverage and having them take care of their other issues, because of course, there's many. And there was one other thing. Oh, so in terms of CalHEP's budget request, so one thing I wanted to give context on is the Safer Injection Supply Clearinghouse. For HEPAC, it would provide us with increased resources to supplement the growing demand of syringe exchange. What we're experiencing in Oakland and in Contra Costa is a lot of opiate pill poppers are transitioning to injection drug use. And so someone did mention that they're under 30. We're seeing a lot of youth and young adults coming to our syringe exchange. So gone is like the average. We have vets who are 40 years and older. We're getting younger. We're getting a younger crowd at our syringe exchange programs in the East Bay. So the clearinghouse would definitely assist with that demand. And a perfect example of a demonstration project, I kept hearing that, is like the integration of services. It's kind of like common sense in my mind. So the integration of treatment at syringe exchange programs, at methadone programs, that could be a good example of a demonstration project here in California in the East Bay. And I thank you for your time.
Quick follow-up question. You mentioned that you were the oldest agency. Are you the largest?
One of them. One of them, yeah.
And so you're not the largest. I see somebody shaking
Yeah,
their
no,
head.
we're not.
Okay.
No.
I'm
Not in California. One of the longest running and
Got
largest,
it. I
but
was just
not
trying to
the
get a
only.
sense when you talked about over 1 million syringes brought in. I'm trying to get a sense of what statewide, getting back to Senator Stone's earlier question, whether or not the state had administered a syringe exchange program.
There's a lot of syringe exchange programs. A lot of them are small. They're on a shoestring budget. Yeah, we're one of the more largely funded.
Got it. All right,
Yeah.
thank you.
Thanks.
Next witness, please.
Hi, I'm grateful to be here. I'm going to try to go quickly. I think some people are hungry probably. So, my name is Paulie Gray. I'm a member of the San Francisco Hepatitis C Task Force. I'm an HIV and hepatitis C trainer and educator, and I do it on 3 continents, or I've done it on 3 continents. I also work in syringe exchange for many years, and I work also in a big syringe needle exchange program. We do 2.5 million syringes a year. And we supply 5 other sites, 5 other exchanges, and do 13 sites ourselves. And we have a staff of 6 people. I've also had hepatitis C for many years, or had for 33 years. And despite the fact that I've had a really healthy lifestyle, like no drinking and, healthy, like scary healthy food, for 18 years, I still ended up looking at cirrhosis. And I tried the old treatment, pegylated interferon, which is a cancer drug that was so nasty, they stopped giving it to cancer patients and just gave it to us folks with hep C. It was horrible, but I was just cured like a month ago after 33 years with a new drug that is not, and it's a good example of this because it's not Harvoni or Sovaldi, it's by AbbVie, it's called Viekira. So we do have drugs coming out and they do work. At Syringe Exchange, part of what I do is try to get people into different kinds of treatment, and I got 8 of my clients treated and they got cured. And one thing to remember is that people who come to Syringe Exchange are taking care of themselves. They care about their health. And you have to be completely clear of drugs for this trial. 3 of these, well, 2 guys and 1 woman went into rehab just to do the hep C treatment. They stayed there. They got clean. There's a big world that can open up here. I think testing and treatment access is really important to fund. And I also think that we're fighting a big beast with this treatment, but treatment is prevention. You can't catch it from somebody who's been cured of it. So it goes around in a circle. And I think it's important in the public eye, they view like needle users as being like almost disposable people. And I'm here to say nobody's disposable. And needle exchange is much bigger than just exchange. People come to us because we treat them well and other people treat them like dirt. So we have like hep C testing, HIV testing, we have healthcare, we have treatment access. They come to us first because they trust us. And I think it's a really good, I think we need to fund the syringe exchange programs to number 1, keep the HIV level, crushed by, sharing needles, which is what syringe exchange has done where it's been active, and also to have a fighting chance against hepatitis C. Thanks very much.
Thank you. Oh, we have a follow-up question. Mr. Stone.
Sir.
Thank you for your testimony today. I'm sitting here kind of in awe that in contemporary society today that we still see people sharing needles, and it was the 2nd largest cause of HIV/AIDS. And is it still the lack of education, or is it the lack of financial resources? What is the etiology of this propagation of this problem, if you will, with sharing needles? Where are we going wrong?
We, in our area, people share needles because they don't have clean needles. People know it's not a lack of education. People are aware that sharing needles is dangerous, but sometimes drug use, I hate to use the word addiction because it's, some people think it's judgmental, but it's a survival matter after a while.
Is it access or is it money? They don't have the money to get the needles?
Both.
It's both.
It's both. And we have 13 sites at a lot of hours of the day. We're doing our best, and we've made a big dent in it, but it's not statewide. So I'm here to support the Hepatitis C Alliance and also syringe exchange programs statewide. We help out as we can, and we do take care of our own. We've kind of crushed, as I said, and if you can look at the numbers, back when I first started doing this work, it was 15–20% of the people in San Francisco were getting it from sharing needles. I don't know of anybody who got it, and that we know got it from sharing a needle last year. It works, you know what I mean? But we have to fund everybody. We have to fund everybody.
Madam Chair, if I may continue, thank you for your testimony. I appreciate it. To the Office on AIDS. As a pharmacist, when we dispense drugs, we have inserts for professionals for us to understand the side effects, drug interactions, to refresh our memories with all the drugs we learn in pharmacy school. And then we also have patient information leaflets. So has there been any kind of a program ever tried in the state of California requiring needle manufacturers, Becton Dickinsons of the world, to put an educational leaflet in the box of needles that talks about the dangers of sharing those needles, and at the same time putting a website down for the state of California, your office, that could steer one in any part of the state of California to where they can get needles through an exchange program? Because it sounds like to me one of the themes of today's hearing on this has been prevention, prevention, prevention. And if we can prevent people from getting these heinous diseases, not only is it going to add quality of life to a lot of these people that need, obviously, to seek help for their addiction issues, but we're talking about a significant expense to the state of California, and we talk about $300 million to try to cure these people. But I think an ounce of prevention goes a long way to trying to solve these problems. So I'm going to work with Senator Monning on this, and maybe we can come up with an idea working with pharma and say, listen, let's go right to the source of the needle manufacturers, and let's have a pamphlet put in there. It's going to be specific to the state of California, so it's going to be a little bit controversial probably with the needle manufacturers. But I think if we work and partner and educate people about the hazards of sharing needles and showing that they are accessible where they can get clean needles, I think we go a long ways to stemming some of the high incidence of Hep C that we're seeing. I was just curious what your feelings would be on something like that. Are we doing anything like that, or do you think something like that would be useful?
So I'm not aware of any efforts to put that sort of labeling within the packaging that syringes are sold in, but I do know that pharmacies can now sell syringes in California, and the Office of AIDS is doing a lot of work in terms of educating pharmacists about that. Even though that's legally allowed, many pharmacies don't know it's legally allowed, or they don't actually sell syringes without a prescription. And
well, pharmacists look at these inserts. So I'm thinking you have a large insert in a box of needles. There could be affixed even to the outside of the box where they see, that they legally can be sold to people coming and requiring them or needing them. And that there's also other avenues for them if financial issues become an issue, that they can go and seek a place where they can get these exchanges for a lower cost or free.
Mm-hmm. Great. Thanks.
I think the pivotal phrase there for me was lower cost and free, because what I clearly heard from the previous two witnesses is it's a matter of economics. And so the insert idea is great, but it's really sheer economics in terms of some of the folks that you serve aren't walking into pharmacies and buying needles. That's the whole point of the exchange. So thank you. Next witness.
Yes, thank you. My name is Lucinda Porter. I'm with the Hepatitis C Support Project. It's out of Sacramento. We've been around since 1998. I am a nurse. I contracted hepatitis C from a blood transfusion in 1988. I've worked in this field ever since. I really applaud the committee's focus on prevention. I think that's really key. I'm going to throw away my notes and just tell you that it's not just about the needle. It's about the water, it's about the preparation, it's about the surface, it's about the cotton, it's about the cooker, it's about everything, and it has to be a bigger focus, and it is about money and access. I think also that we have to keep in mind hepatitis C lives on a surface for up to 63 days. It lives in a syringe for 63 days. Yes, up to 6 weeks on a surface, 63 days in a syringe. This is a highly infectious virus. I also really want, it's already been said that people, that more people die from hepatitis C than from HIV every year. That's true. We also know that the prevalence rate of hepatitis C has been dropping according to the CDC. That's because people have died from it, so that drops the numbers down. But the overall infection rate is increasing. It's increased 75% at the last CDC surveillance statistics. And there's mostly in under 30 set. So we really have an issue here. I really want to support the California Hepatitis Alliance budget request. And on a personal note, I've noticed that there's some people here who look like they might have been born from 1945 through 1965. Please get tested. It's not about whether you had another risk factor. It is about whether you were born in those years, and don't assume your doctor tested you. Thanks.
Can I ask you a follow-up question before you leave? Yes. Pardon my naivete, but something you said triggered a memory. At a health committee hearing or some convening here where we heard testimony from young people who talked about tattooing instruments and needles. And so where's the public education in that realm? Or the new restrictions in tattoo parlors in terms of new needles every time, I'm assuming, is that dealt with the issue, or do you know?
Generally, on a commercial level, the tattooing and piercing are fairly safe because they have standards to follow, and that's not to say, just like in healthcare, those standards can't be breached. Right. But really, where the problem is tattooing in prison and tattooing in the neighborhood, and then and these tattoo parties and piercing parties that are showing up are really disturbing because they don't have the professional. They don't have to protect the professional, future clients. So.
Or the tattooing that's going on in group homes and foster care. Exactly. There's a number of foster care kids who are under 18 who should not be able to go to a tattoo parlor because of age and get a tattoo.
And that's why they can go there.
Or in the drug trafficking realm, the women who are having, the bar scans that are tattooed on them. Yeah. And not sure who's doing those. And so that could be a whole new generation.
Oh, believe me, there's plenty of opportunity out there.
Hep C. All right. Thank you. Okay. Appreciate it.